Tika. We are the diagnostic team and we'll take you through our remarkably interesting case study. So thank you for joining and let's get into it. So our patient today is Mr. Rene. He is a 26 years old man and he had a car accident. I'll leave you with Ebony. She will take you through the physical examination conducted to Mr. Rene upon the observed sign and the symptoms he were experiencing. Thank you, Ebony.
Thank you. So, just quickly, I want to note that a sign is a clinical finding that is observed by either the clinician or another medical professional, whereas a symptom is an abnormality reported by the patient, family member, caretaker, and so on. So, upon presentation of the patient to the hospital, our team observed signs of bruising on both thighs, lacerations to the left thigh, cold and sweaty extremities, abrasions to Mr. Rene's face, forehead and temple, as well as a reported loss of 1 litre of blood at the site of the accident. The signs that Mr. Rene presented were confusion, complaints associated with nerve lesions, as well as semi-comatose state. So, due to the observed signs of head trauma, as well as the symptomatic complaints from Mr. Rene, our team conducted a full cranial nerve examination on the patient. So, upon examination of cranial nerve 1, the patient was unable to smell in both nostrils and had discharge from the nose, resulting in the diagnosis of anosmia and mild rhinorrhea. So potential cause for the anosmia is a lesion to any of the nerves that make up the olfactory bulb or along that pathway. So the pupillary light reflex was negative for both the direct response in the right eye and the indirect response in the left eye. Assessments of cranial nerves 3, 4 and 6 for extraocular movement resulted in nystagmus in the patient's left eye upon abduction, as well as non-functioning adduction of the right eye. This is indicative of a lesion in cranial nerve 3. So cranial nerve 5 assessment indicated reduced sensitivity for fine touch and temperature to the patient's right side of their forehead. Blink reflex was negative for both the direct response in the right eye and the indirect response in the left eye. These two assessments combined indicate a lesion in the right ophthalmic division of cranial nerve 5. Assessments of cranial nerve 7 to 12 all produced normal results. So 2 tuning fork hearing tests were conducted on cranial nerve 8. So in patients with unilateral hearing loss, the Weber's test is used to distinguish whether it is conductive or sensory neural hearing loss. Then the Ryan's test is frequently used in conjunction with the Weber test, and it compares bone and air conduction in order to determine the location of the hearing loss. So Mr. Rene's hearing test results were all normal and were not indicative of either a central or peripheral lesion. And I'll now leave you with Rachel, who's going to go through cranial nerve 2.
A confrontational visual field test was performed to assess the optic nerve. During the examination, the left eye was found to be healthy. The right eye, however, had a normal temporal field, but a deficit in the basal field, being a right basal hemifield. This indicates a lesion in the right peritasmal region, as is shown in this diagram. Yeah. Alongside the neurological tests, we also performed other tests in order to diagnose the patients. This included some biochemistry tests, which I will now discuss the significance of. The levels of hemoglobin, albumin, and creatinine assisted in determining how well the kidneys were functioning. Hemoglobin is a protein found in red blood cells that transports oxygen throughout the body. So the amount of hemoglobin in the blood would indicate a lack of red blood cells, which would result in anemia. The patient would present feeling weak and tired due to the lack of oxygen circulating, as was observed with this case. This can have various causes, including excessive bleeding and also kidney failure, as the kidney as the kidney makes erythropoietin, a hormone that aids with the red blood cell production. Excess hemoglobin in the urine can be present for a variety of reasons, including glomerular necrosis, which is inflammation or damage in the glomeruli in the kidneys, which affects the filtration of the blood. Albumin is a protein in blood plasma that keeps fluid from diffusing out of the bloodstream into the intracellular matrices of tissues. It also helps to transport hormones, vitamins, and other substances throughout the body. It is produced in the liver and it's filtered in the kidney. Therefore, if there is a low albumin concentration, as there was observed in this patient, this could mean complications with those organs. And in the case of kidney failure, the albumin would be lost through the urine. Renin is a breakdown product of creatine phosphate in muscle tissue. Healthy kidneys filter this waste product out of your body, so there should be a minimal amount present in the blood. A high amount present in the blood would indicate kidney failure, as was seen like with this patient. I'll now hand off to Aisha for the patient's results.
So before I do the results, I'm just quickly going to go over the two types of errors that can be encountered when we do the test. So there's type 1 and type 2. Type 1 error is a false positive result. So when we test albumin, it can come up as liver disease, and that's obviously wrong. So then there's type 2, which is a false negative. So when we test creatine kinase, and there's like muscle damage, we cannot, if they do not diagnose it with rhabdomyolysis, that's not good. And then to avoid those errors, there's specific tasks taken. So we do standardization control samples, training and competency assessment, and external competency assessment. Now the independent, dependent, and dependent control are the concentration of the serums, and the dependent variables are the levels of albumin, hemoglobin, and creatine kinase. The control variables are the types of blood sample collected, the equipment, and the reagents used to measure. Now let's go to the results, and we can see the hemoglobin and hemoglobin results are fairly low, which means there's not enough oxygen in the blood, and the patient will feel fatigued and tired. The albumin results at 26 hours are also fairly low, and my voice will previously explain that it indicates to kidney disease. The creatine kinase results at 26 hours are elevated. They're very elevated, and this is an indication to kidney disease as well. Now so that's how I can come back.
Thank you, Kritika. So our patients suffer from hemorrhage. So that we conduct a blood pressure measurement to observe the blood flow in response to the hemorrhage shock, followed by an ECG to address any potential dysrhythmia. So how do we do blood measurements? Well, the heart contracts and eject blood. The blood flow through the arteries produce pulses. These pulses we are able to hear using the stethoscopes via the main arteries in our body. For example, in the arm is the brachial artery. Sphygmomanometer will record the pressure in millimeter mercury. So we rub the cuff around the left arm, squeeze to reflect the cuff, and then when the reading approach 140, we start to slowly release the valve, and then we hear the sounds. When at the first point we hear the sound, this will be the diastole reading, and it will represent the heart contraction. At the first point, the sounds fade. This will be the systole reading and represent the heart relaxation. Now, precautions we should take to maintain an accurate reading is taking the medical history of the patient and the medications he is on, plus applying the right side of the cuff and apply it on our arm. Now, our patients suffer from hemorrhage, as a result hypovolemia. So the blood pressure reading was hypotensive. A low blood pressure report of 90/60. followed by an ECG to address any potential dysrhythmia. It was normal aside from tachycardia, so his heart was beating fast, 130 beats per minute. So how this high heart rate and low blood pressure presented on ECG? Well, it represented as a tachycardic pattern. As you can see, a rapid induction of the cardiac wave compared to the normal ECG. So, how tachycardia associated with hypertension? In hypertension, sympathetic nervous system will be activated to release epinephrine. Epinephrine will act to raise the blood pressure. It will act on the vessels to cause vasoconstriction. It will act on the heart to increase not only the heart rate, but also the force of the contraction of the heart. So the heart can eject the maximum volume of blood, or as we call it, the stroke volume. If we elevate stroke volume, we will be able to elevate cardiac output to retain the normal blood pressure back to normal, so that we maintain a peripheral perfusion and adequate oxygen supply to our organ. Otherwise, hypoxia will be a result. Epinephrine will bind in the kidney to induce the release of renin. Renin will activate angiotensin II. Angiotensin II will act on the posterior pituitary gland to induce the release of antidiuretic hormone. Now, antidiuretic hormone will act on the collecting duct in our nephron to increase daily absorption of water from the lumen of collecting duct back to the blood plasma to compensate the hypovolemia, increase the blood volume, and elevate blood pressure. At 36-hour observation, our patient was able to retain a normal blood pressure and heart rate. However, he was found to be below hyperkalemia and acute kidney failure. Hyperkalemia was observed by two types of tests. First, the blood test, which clearly revealed an elevation in potassium level, as we call it hyperkalemia. On ECG, it was represented by a tall 10-wave T wave, as we can see in V2, V3, and V4. So how T-wave is linked to hyperkalemia? T-wave represents the rapid repolarization of the heart or the systole, and that occurred by the opening of potassium channels to allow the rapid efflux of potassium outside the myocardial cells. When the when the concentration of potassium in the extracellular environment is elevated, that will obstruct the rapid efflux of the potassium outside the myocardial cells, and that will result in a slow repolarization. Presented on ECG as a tall, wide T wave as the repolarization is taking longer. So how hyperkalemia has been developed? Well, it's all started from the compartment syndrome. And now I will leave you with Rachel. She will take you through the compartment syndrome. Then Kritika will take over to explain our analysis. Thank you, Rachel.
Acute compartment syndrome, or ACS, is a painful condition occurring when there is an increase in interstitial pressure within the closed osteofacial compartment, which impairs local circulation. ACS can occur as a result of a severe injury, such as fractures or crush injuries. It's most common with injuries to the legs and forearms. This triggers an inflammatory response leading to tissue edema. Rene also has bruising on both his thighs and laceration on his left thigh, which would be consistent with this. The pressure buildup can lead to muscle necrosis, resulting in crush syndrome. This would be marked by the rapid hypoxia, renal failure, and cardiac arrhythmias. I'll now hand over to you.
So what is epilepsy? It's a condition where muscle fibers break down and release their contents into the bloodstream, including myoglobin is then
1 minute, guys.
myoglobin is then filtered by the kidneys and causes real damage to the renal tubular cells and also a kidney injury. Patients also present with brown urine, which can lead to myoglobinuria, large amount of urine red blood cell and blood. This other signs of myglobin are also pain, weakness, and disturbance swallowing gut urine. Urine types of hemodialysis of this patient is following. There's hyaline cast, granular cast, waxy cast present, and hyaline cast and waxy cast are made from tan postal proteins and degenerated tubular cells, and they are all indicated for kidney damage. Some of them are talking about other results.
So the creatinine and urea were dramatically elevated over the plasma, and that combined with the low urine output all were indicative of an acute kidney failure. Acute kidney failure results in reduced the level of bicarbonate in the blood plasma, and this is resulting in metabolic acidosis because the kidney was unable to reabsorb bicarbonate back to the plasma. That dropped the pH of the blood, bringing to the acidosis site.
So final diagnosis is that Mr. Rene's accident and subsequent injuries caused compartment syndrome that then resulted in rhabdomyolysis. This then caused acute kidney failure and hyperkalemia. Mr. Rene also sustained a head injury that caused lesions to cranial nerves 1, 3, 5 and to the right perichiasmal area of cranial nerve 2. Thank you for listening.
Good guys, a little bit over time, but that's fine. Thank you. Questions? Started today. Everything very clear. Evan?
I'd just like you to confirm for me the difference between a type 1 and a type 2 error.
So the type 1 error is a false positive,
Yeah.
and the type 2 is a false negative.
Yeah. But what would the examples you gave? Were you concerned that are correct?
So type 2 error is where muscle damage, if presented with muscle damage, then there's kidney disease. So there is kidney disease present, but it's not shown in the results.
Okay.
Yeah.
And can you just go to the next slide and just explain that again so quickly? Which is dependent and independent?
The concentrations of albumin and the depending the levels of the serums. So how much volume?
Anybody else got it? I've got plenty of questions for you.
Just one more. On the explanation on the acidosis, you mentioned the bicarbonate. Are there any other elements in there?
Hydrogen ion. Not the hydrogen ion.
The acidosis is a lot of hydrogen ions.
Yeah, lots of
Wow.
hydrogen ion in the blood because the kidney normally function to maintain acid-base balance. So it excretes hydrogen ion to reabsorb bicarbonate back to the plasma. So in acute kidney failure, this normal function is disrupted. So
In this particular case, there's one more reason why the
urea,
pH is low.
Nothing to do with kidneys,
Nothing in the kidney, nothing with the muscles.
with the rhabdomyolysis.
the breakdown of the proteins,
Of?
the proteins, no?
Lactic acid is being released when you have the cell being destroyed. There's a lot of lactic acid because they have anaerobic metabolism because of the lack of blood,
Yeah.
the lack of oxygen, the lack of blood supply, lack of oxygen going to an anaerobic metabolism. There's a lot of lactic acid being produced, and that's a
And that accumulates hydrogen ion in the blood, right? And we'll
Acidosis,
be,
yes,
yeah,
yes.
we'll be able to excrete it.
Any questions?
I have no questions, no comments.
All right, so let's just give you some feedback. So thank you very much.
Yeah, well, I thought you did a fantastic job. I mean, you did go, the time at the end, you were really racing to get all the information out there. And that's understandable because you presented a lot of information, but I guess that was one thing, it's just a little bit out of time. I really like the way that you all shared in the presentation and the way that you made the presentation, you know, in a nice story. I thought that was great, the way you presented the kind of science and symptoms and explaining it. It's fantastic. I think you covered just about everything very well, and I think it was quite clear to answer all the questions that were asked. So I think you did a fantastic job. One thing I think you do need to do is not to cite lecture notes as bona fide primary lecture sources of information, which, you know, that should be primary sources, so that's a problem. But other than that, I really enjoyed this talk. So thank you.
Yeah, so I thought that the presentation, the slide management was very good. font size and the distribution, and I like the initial images that sort of started the whole thing very well. Good explanation in the beginning on the cranial nerve examination and the diagnosis. Perhaps a summary diagram would be good. You did that well with the post-chiasmal lesion, so something similar would have been helpful, like an image to help people understanding which nerves were compromised. I like that you were highlighting in red and then the explanation. I thought that went smooth and well. Just a diagram could have come good. You discussed a list of the biochemical tests and explained what they were meant. It would have been helpful perhaps to talk about the actual data. So in that particular patient, as you were explaining them, perhaps in the slide itself, saying, well, this was low, this was high, or something happened, it was not affected, or whatever. The explanation was good to explain what the exam, what the tests meant, but it was difficult then to follow because it was in a separate slide. So perhaps incorporating both would be helpful to follow. I like the idea of the flow chart. In the hypertension, you had it there, but you didn't use it. So there's a flow chart explaining, and that wasn't used. I thought it was a good idea to have it, but it could have been used and exploited. The explanation on the potassium level was good. I like that. The way you went through that and the reasons and how you went through that. You also spend a good amount of time explaining the hormones involved in the response to the hypertension. I thought that was helpful. Again, I think you had a figure there that wasn't utilized. You had a figure of the point at which the various hormones work that could have been used better to explain, just to support you while you were speaking. I thought in terms of the presentation overall, you did a good job. Probably rehearsing a little more will help you managing the time better. I noticed some people have different skills on engaging the audience, and some people are better. Overall, I thought that the job was well done, despite the limitations people may have. I thought that overall it worked well.
Yeah, good job, girls. Just to add on to that, I think I had a couple of comments. Mostly, one of the things was that a lot of the figures you chose were not so great, and it was just talking about terms of quality of the figure itself. The internet is a vast, broad space of pictures, and we could probably pick some other ones. Something like a little bit hard to read. Especially they would photocopies from like books and stuff. The contrast is a bit hard to read, especially on a projector. Proofreading, a couple of mistakes in there, like font size differences, and just a couple of things that would have added like a nice finish to it. Basically, it comes across as noticeable. Maybe some more proofreading would have done. The beginning of the presentation started off really well in the layout of the slides, and then it kind of got a bit boring after that. They were just, yeah, a little bit. It's not fully strong, and then I was looking forward to it, and then it kind of just went to like text on black background kind of thing. But I do like Alejandro said that you're using red to highlight the diagnosis part. It helped when you guys were going through and saying what they were. I could see it. The order was a bit weird. I guess most people start with the echocardiogram stuff, the ECG stuff, and I haven't seen it many times where you start with the cranial evaluation. I suppose in my mind I'm like, this guy's coming to the hospital or whatever, and trying to sort out his heart problems and keep him alive first, and figure out if he can hear later. I don't know, just a comment. I was unsure about how everything went opposite way.
I quite like the flow myself.
But I had the same comments about proofreading. I actually had like some problems with the slides. It looked like you were sort of pasting things in. Like there are a couple of different fonts, text sizes. Within one dot point, there would be a different text size, and there are a couple of typos that I noticed. Just someone to proofread over it, I think would be really handy. I agree. I think you could have utilised some picture better. You went through the cranial nerves, you explained them beautifully, and then you had the picture, then it was just to the next slide. It would have been better to sort of have the image talk me through it as you give me those explanations. And then the same with the biochemical tests. You were talking me through them, saying if this is high, if this is low, this is what it means. Just give me the number at the same time and tell me what it means. I think if you're explaining it, give me the result, and then because I think that possibly cost you a bit of time to take me through everything, then tell me the results, and then tell me what they all mean. You know, tell me what the test means, what your result is, and then what it means for the patient. I think that would have just helped you with time a bit. But yeah, proofreading is the only thing I had. Otherwise, you all spoke clearly, confidently. Yeah, good work.
Thank you.